Recording in progress.
So, good morning all. This is Dr. Joshna. I am a consultant ENT and also head and neck oncosurgeon here at Sagar Hospitals, Jayanagar. So, I would like to ask you a question even before I start. Which do you think is the most common cancer in the world? I'm sorry? No, in the world. Overall. Yeah, that is right. In the men? No. Yeah. So in the world, actually in females, it is breast cancer. In the males, it is lung cancer. Okay. And do you know where we stand in India? What is the most common in men and what is the most common in females? That's correct. In the last 2020 Globocon, the oral cavity cancers has actually exceeded the lung cancer rate as well. Okay. Right now, oral cavity cancers are the most common cancers in men in India. Okay. And there is a fourth or fifth most common in females in India. Overall, in India, it is the third most common. Okay. So with that introduction, we'd like to go ahead. Not able to change. No. Okay. So we talk about the oral cavity cancers and it is almost synonymous with the squamous cell carcinoma because it represents 92 to 95% of all the cases of the oral cavity malignancies. So it is one of the most common types, as I told you, in India. Okay. So the data from the Global Cancer Observatory, they said in around 2020, they saw nearly 370,000 beyond cases overall globally. And most of them, they had come from Central Asia, which is nothing but India, Pakistan, Sri Lanka, and Bangladesh. But I would say this is highly underrepresented because most of all these countries, there are so many regions where they don't even have the proper data system. They don't even have the proper reporting system. So this is highly underestimated number. So we all know that the age predilection is from 4th to 6th or 7th decade also. And male to female ratio is 2:1. As I told you, us Indians and the Central Asian parts, we have this burden and we have few challenges as well. Okay. So it is the most common in India amongst the men. As I told you, it represents 16.28% of all the cancers in men and fifth most common in women. And it represents 4.3% of all the malignancies in women. And overall, it is the third most common. I have already mentioned to you. So why is it a challenge to us? Because of these three factors which I have mentioned here. One is time, because there is no awareness among the citizens here, especially in the rural background. They don't even know what cancer is, and they don't even know what an ulcer will look like. They will just think there is some wound, it will go off, correct? So by the time they actually think they have to come to the doctor, it is already late. And the diagnosis as well becomes late, and hence the treatment outcomes as well. The second one is the facilities. As I told you, in the rural and middle and lower community in income countries, they have inadequate access to the trained professionals. Yes, in India, we do have trained professionals, a lot actually, but in the tier 2 and tier 3 cities, not in the rural areas. We all know, we all stay here in Bangalore, correct? And the last one is the money. Even though the person is having the facility, even though he recognizes it earlier, but he doesn't have the income to get the treatment done. And this is like proportional. If the higher stage of the disease, higher the amount he requires to get it treated. So these are all the things which we have. Now, just to elaborate on the time thing. So if you can see here, by the time a person sees, for example, bleeding from the gums, right? So if there is bleeding in the gums, we all must have had it at least once. We don't care about it. Similarly, in the rural areas also, they don't care about it till actually it bothers them. Till there is actually difficulty in swallowing, or there is big wound which they are unable to open or close the mouth, all those things. So there is a delay from the patient side itself. By the time he at least approaches to the nearby hospital, that is a PHC, we can talk. So by the time they actually contact the healthcare and they actually go visit the healthcare is also a delay. So once they actually go visit the healthcare people in PHC, they have to recognize it first of all, and then they have to refer it. So there is again a delay. This is called primary healthcare delay. So once the specialist doctor sees the patient, then obviously, if a person is from Kunigal or something, he doesn't have anything around. So he'll be sent to the nearest places. So he'll be made to run around for the diagnostics itself. There is a delay there as well. By the time he actually receives the treatment, it is already really, really late. And it is already progressed to the higher stage. And the prognosis definitely drops by 50%. Correct? So this is the delay. So what is the cause? We all know, even like a person on the road, they can tell cancer, smoking or alcohol, they can tell it by themselves, right? So in the tobacco itself, more than smoking, I can say tobacco, which is smoking and also non-smoking type of tobacco, and alcohol as well, okay? Tobacco itself has 1.9% risk than non-smokers. The alcohol has 1.75%. Say if a person is having at least 2 packs of cigarettes a day and then 4 packs of alcohol every day, then he has 35% more chances of having a cancer. That is the exponential risk rate, right? Also in India, if not outside, in India, we have betel nut chewing and also smokeless tobacco, which is more here, gutka, palm, all those things, right? Then we have few organisms which cause that, which is human papillomavirus. In some, we have EBV also, which causes Kaposi sarcoma, if not SEC, okay? And then we have Plummer-Vinson syndrome. We have all associated Plummer-Vinson syndrome with, and what does it gives rise to in the future? Yes, and which causes post-cricoid webbing, and which is the pre-malignant condition. And also it is responsible for CA esophagus also. But this is a new thing, that it is also having some effect in the oral cavity. So whenever there is siderophilic dysphagia or siderophilic iron deficiency, there is blackish discoloration of the whole mucosa, and also chronic inflammation sets in, which by itself is a pre-malignant thing. Okay. And long-term immunosuppressions, for example, these HIV patients and other immunosuppressants who are people who are taking it, all of them are actually prone to chronic inflammation or repeated infections and further chances of pre-malignancy and then malignancy. Now, ill-fitting dentures is one of the most neglected things. So many people which I have seen here, they have come with the chronic ulcers and we have excised it because of the ill-fitting denture, because there is chronic trauma there again and again and again, that the mucosa itself there changes its characteristics. Now, that is a repeated trauma as well. And the pipe smoking or water pipes, have you heard of shisha? Like it is a fancy thing, and also called vaping, which is e-cigarettes. Okay, and also for the lip, it is a chronic exposure of the UV rays. So here I have just mentioned few things. So the BDs and cigarettes, they all are form of like a tobacco smoking. And this actually gives rise to, and also the non-tobacco smoking and non-smoking tobacco. So this gives rise to nitrosamino-butanoid or nitrosamino compound, which are highly toxic. Okay. Now coming to this e-cigar, they say what vaping. Nowadays you go to any place, like there are kids who are using this. Kids, I mean, they're like around 18, 16. Okay. So they say this is not having anything, but they are wrong. Now there are studies that they say this has equal risk as cigars, because can you see this liquid inside in the cylinders? They might contain tobacco, okay, and also the vapor which comes out of it has toxins, okay, and the tobacco which is there in that makes it addictable, like if they get addicted to it. So similarly with the shisha as well, when there is a charcoal and there is a tobacco, the infused water vapor only the person is having, and if they do one shisha, it is equal to having one cigarette. Okay, so that much is a risk. And we all know about the pan, gutka, and all that. And the arachidonids also, you must have heard about the quid, where the betel nut is along with the arachidonids and also lime. All these things put together, like a pan masala, they sell it as well commercially. So at the end of it, you can always divide them into these things. That is non-modifiable. My age, gender, ethnicity, or socioeconomic status to some extent can't be changed. These are non-modifiable. Whereas modifiable are your habits. You can always work on them. And for the HPV, you can always get some vaccines, right? The emerging ones. Good morning, sir. The emerging ones are human papillomavirus and the May drinking. This is a new thing where there is caffeine in the thing, and also the it causes chronic inflammation of the oral cavity as well, and the immunosuppression. So far I have covered the epidemiology. I'm going into the risk factors. Oh, sorry. So that much I have covered, sir. I'm going into the risk factors and further. So the factors which have limited evidence, but I feel it has strong evidence, is the poor oral hygiene and dentition and indoor air pollution. Okay. And which does not have much of research yet is mainly the alcohol containing mouthwashes. Do we use that or not? Okay. And cannabis, definitely people who are doing the cannabis, they will ask like, that is safe, but not really actually. So is it all gloom and doom? Till I have explained how scary this is, but is it also, but not really. We do have prevention methods, primary, secondary, and tertiary. And also nowadays with the invent of the social media, the awareness is reaching to people beyond the cities. Correct? So they are aware of the self-screening methods. They are aware of like how an ulcer would look, how the cancer would look, what all things. So it is reaching. We are in the right path, but not yet, because we need to reduce our habits as well. So what is the primary prevention in any type of cancer? What is it actually? You must have heard all the cancers, right, in the whole body. So first one is prevention. So please stop all the habits and all the like carcinogenic risk factors. That is your primary one. You won't get it if you don't have those risk factors. Second is secondary prevention. So once you started getting some ulcers or started getting some leukoplakic patches or anything, you recognize that and exercise and stop your habits. You're preventing at that stage. That is your secondary. What is tertiary? You've already got cancer. You've already been treated. Now you're making sure that you won't get second primaries or recurrences. Correct? So these are the primary, secondary, and tertiary prevention methods. So now finally jumping into the pathophysiology, we all know about this Nathan's 2 hypothesis we have seen in all the cancers, correct? So in the sporadic cases which happen, which is the most common type in this oral cavity cancers, a person will be exposed to long-term risk factors. There'll be one hit or a chromosomal allele is damaged. If he is exposed to further the same risk, the second hit as well happens. But in very few patients, they are genetically susceptible as well, where they already come with one defective allele. So you are exposed to that and you are more prone to getting the cancer even before others. Now, the cancer stem cells, again, I have just mentioned some 2 to 3, it's a multifactorial, multi-step process of the carcinogenesis. I can't cover in this 1 hour's time. So that is the reason I just mentioned 3 or 4 of them. So this cancer stem cells, so we all know that we have a epithelial, right? It has a basement membrane, then the stratified squamous epithelium. So in the basement membrane, coming to that, we have few stem cells, okay? So these are for the wear and tear. Whenever there is some damage, it is send its daughter cells to differentiate and replace the tissues. So that is the power of it, right? So whenever a person is exposed to these toxins, there is damage to these stem cells over and over again. When it is exposed to that, what they do is they lose the inhibitory pathways of like apoptosis, and it will gain these features, okay, to become cancer stem cells.
Intestinal cells multiply and close the specification to replace for frequently. How many frequently the oral cavities and some replace?
I am not sure about the exact date, sir, but it must be in around 1 week's time. I can confirm and tell that to you, sir.
I think that is the most important thing we need to realize. Apart from the fact that we have all these treatment activities and the benefits to the position and amino acids, cells that multiply frequently. There is potential for them for the during the process of multiplication, there will be a slight change, and this change will keep on increasing. When it reaches this stage, where it becomes this class, this level, this disease. So this theory has been well documented for all cancer.
It's not so much studied about, sir, but I'll look into this and get back to you, sir. So these cancer stem cells, they acquire these features, making it like kind of immortal, right? So it's self-sufficient growth signaling, anti-growth signaling, insensitivity, efficient of the apoptosis, unlimited replication potential, sustained angiogenesis, and tissue invasion and metastasis, of course, in the final stages. Now, this is something which I am very interested in, and we actually have studied regarding this. That is the oral microbiome. We all have studied about gut microbiome, isn't it? Actually, a human body has more genome of the microbes than himself. Okay, so that is we all actually right now call it as a holobiont. Holobiont, where symbiotes, commensals, and the pathogens live here, right? So similarly, we have a flora in the oral cavity also. There will be certain group of microbes which are protecting you, certain groups are eating off you, and certain groups which are helping you in the immunity and those things. So there is a flora with some ratio, which is not recognized, by the way. Okay, so whenever a person is exposed to any of these bad things, for example, poor oral hygiene, bad habits like smoking, tobacco, or any of these things, there is change in this microbe flora. Okay, your pathogens are going to increase, causing more chronic inflammation, and further releasing all the toxins, reactive oxygen species, and pro-inflammatory cells, which further causes cancer. Okay, actually, this is a picture from the study which we have done already, yet to publish. So here we can see the chromosomal anomalies as well, or the defects which happens. So in the normal and most probably the hyperplasia phase of it, we can see 9p loss or 3p loss, and mild dysplasia, moderate and severe, they usually contain the following chromosomal defects, that is 4q loss, 6q loss, 6p loss, etc. And finally, when the carcinoma in situ sets in and the further progresses to invasive carcinoma, there are further increases in the chromosomal defects. So if you see in the second row and the first row, the first one here, this is a regular size of the epithelium, and this is a regular appearance of the mucosa as well. In the hyperplasia, you can see there is increase in the thickness of this, and there are slight changes in the mucosal appearance as well. In the mild and moderate dysplasia, you can see the thickness increases drastically, and there are kind of invasion into the, just pushing of the stroma is present as well. In the severe dysplasia, you can see this finger-like structures which are coming into the stroma, and here in the clinically, you can see that this leukoplakic patches are increasing in size and also the depth of it. The carcinoma in situ and the invasive carcinoma, you can see the size of it, and also the texture of the lesions also will change. This is just briefly regarding the pathophysiology. Now, this one last thing which is included in that as well is field cancerization. Can any one of you tell field cancerization is? Have you heard that in the GI system or anywhere? No, right? So let me explain. So this gentleman, Slaughter et al. And his faculty, Slaughter et al., they actually coined this term called as field cancerization. What is it actually? So when a person is exposed to drinking or smoking or any of these toxins, he's just not exposing one single part of the mucosa, isn't it? The whole cavity is exposed, the whole GI system is exposed similarly. So when a person is having one single place carcinoma or this pre-malignant lesions, the whole other mucosa also are equally susceptible to having further cancers as well in the same time or in the future. Okay, this is called field cancerization. So it is actually defined as a field of cellular or molecular alterations that predispose the development of neoplasms within that particular territory. Okay, so what are the different things? If you have seen, we have seen in oral cavity, there are multiple leukoplakic patches, there are multiple erythroplakia, multiple cancers as well. We have one in the gingiva, the other one is in the alveolus. Like we have seen such, we call this like second primary, third primary, like that. So what are the theories? So here, if you can see the first one, the independent event. So the whole mucosa is exposed. The same kind of process can happen anywhere in the mucosa. The second one is migration of tumor cells by means of saliva or food or anything. So there is a inflammatory thing or the carcinogenesis which is happening here. The cell gets transposed to the different part and gets the lesion as well. The 2B, that is the intraepithelial migration. This is still the migration, but not outside, but inside the epithelium itself. So these are all the three theories of field cancerization. So with this, we are done with the epidemiology, risk factors, and pathophysiology as well. Now, coming to the clinical presentation. So most of them actually, if they have good screening capacity or looking at their own mouths or anything, they usually come up with, they have a white patch, I have some lump, all these things. So if they're recognized in the earlier stages, the chances of cure are higher as well. Okay. So red lesions usually are asymptomatic. and it can already be either carcinoma in situ or invasive carcinoma itself. Okay.
Lichen planus also.
Yes, sir. Yes, sir. It has 0.4 to 4% of malignant transformation.
But erythroplakia and leukoplakia
More, sir. I'll be mentioning it right now. So these are now, initially they used to be called as pre-malignant lesions. Right now they are called as potentially malignant lesions. Okay, now the term has been changed. So this itself is a huge class actually, but I'm just mentioning the names of it and the risk factors. So leukoplakia is the first picture which you are able to see, and this is the hyperplastic leukoplakia where they have they're gaining another dimension also, that they're growing outside. And the third one is your erythroplakia, and this picture is the oral submucous fibrosis. The last one, this one is the reticular pattern which you are seeing, that is the lichen planus. Okay, so the leukoplakia mostly have again around 3.4 to 9% of malignant changes. Okay, the hairy leukoplakia now it jumps, it becomes 15%. The erythroplakia is the worst of all. It has 15 to 50% of malignant transformation. So a person is having erythroplakia, most of the times he is bound to have cancer in future. Now lichen planus, as I was telling sir, it is only from 0.4 to 4%. That's all. And oral submucous fibrosis has around 4 to 8% of malignant transformation changes. So this always have to be kept in mind. Okay, if they go beyond a size of 1 centimeter, it is advisable to take it off and send it for the like histopathology to see if already carcinoma in situ is there or not.
See for example, there is a patch of leukoplakia, you either using laser or whatever you excise it. When, if, for example, the person now stops the risk factors, will the leukoplakia recur there?
Sir, already. So again, it comes to how much risk factor will be there for a person who is smoking and not smoking, sir. Even if a person stops it right today, it will take another 10 years for him to come back to the person who is non-smoking. So there are chances it can come back.
But because this lichen planus, one of my friends had it, the problem is even if you excuse that,
Just
it
going
will
to
come back.
Yes,
Because everyone will be the etiology.
it's an autoimmune.
Yeah, so probably because of that, the risk factor exists.
Yes, sir, it does.
Will it increase with the age of, for example, like a friends of this for 15, 20 years?
It does. It does, sir. So this is all like a risk stratification, sir, which is not well studied yet. But when the person's age increases, or if he's got susceptible like parents, like he also is having, all these factors actually add up to increase the chances. And lichen planus is not exactly due to the risk factors of like smoking or tobacco, sir. It happens by itself. So when it comes to leukoplakia and erythroplakia, as I told you, it at least will take 10 years. As we all say, there is no safe smoking zone. There is no safe alcohol thing. People say you take 1 peg a day, it is good. No, there is nothing. Now the research, it says it very clearly. There is no safe alcohol amount which you can consume. Okay. And similarly with the smoking as. Now coming to the actual symptoms of the cancer. So definitely bumps, lumps, whatever in the the common language which they tell, like swellings, crust, and rough spots on the lips or inside of the cavity. A person might have like red or white patches, as I was telling you. Person already have ill wearing dentures. It might be hurting, or it might cause bleeding in the gums also. And unexplained weight loss and sudden weight loss and loosening of the teeth. That is very important. Loosening of the teeth, that gives us a lot of information. And sudden bleeding from the mouth, trouble or pain while drinking or swallowing, meaning that means it has progressed to beyond the oral cavity. And chronic sore throat, stiffness, pain in the jaw or tongue. So here, coming to these pictures here itself, you can see that this is a ulcerative lesion over the tongue. And here you can see it is in the lower alveolus. You can see here, can you see this loosening of the teeth? I mean, by look itself, even before palpating, you can tell that. And this is a ill-fitting dentures or the implanted teeth, right? Can you see this? This is a chronic inflammation which will happen and further turn out to be SCC. And this is the angle of the mouth one. And this is the superior gingivobuccal sulcus. Okay, this actually was in this patient was going on to the maxilla as well. And this is a lump. The person had just come with some lump is there. And then you actually do the proper evaluation and this turns out. Like similarly in our patient, one of ours, he had come with a neck lump and it was thought to be like, abscess. They had done IND and all that. But when I actually looked into the oral cavity, there was a small ulcer, which had given to such a big second. Can't see. Now, this one is a proper proliferative exophytic growth. Okay. Along with that, he might have like chronic dysphagia, paresthesia, loose teeth, restricted tongue movements, and restricted mouth opening, trismus, and ulcer. So when there is an ulcer, it is staying beyond 3 weeks and it does not look bad. Also, you still go ahead and take a biopsy and send. Okay. When the pain is not an initial symptom. There is a reason it gets delayed actually. And it actually happens when there is infection. Second thing is when the ulceration becomes more and the nerve endings are exposed, or in few patients, the nerve are infiltrated also. In these things, there can be pain. The trismus, it either can be due to pain or it can be due to few spaces, that is masticatory space or like, the pterygoid muscles. All these things can give rise to trismus. Otalgia, we all know that it's a referred pain. Dental pain, bleeding gums, and all this I have explained already. The numbness also, it is because of involvement of the mental nerve, inferior alveolar nerve, all these things. Now, coming to the history and this one, history we all know, like, however you explain any other case, this is the same way. You are going to explain the type of the lesion, duration, onset, progression, any other similar lesions, all kept aside. You are going to concentrate on the negative histories. That is, neck lump is there, loosening of teeth is there. Whatever I mentioned just earlier in the slide, you are going to ask all of them, including bad breath, trismus, or rhinophagia. But is this it? No, you are supposed to go ask in the past history if any such histories were there. Or social. Social is very important in this. How long have they been smoking? How many pack years? How much of alcohol have they been consuming? Any other habits were there? Any unsafe oral sex habits they had? All these things we have to ask. Now, coming to the evaluation, like we have to have a clinical evaluation, radiological, pathological, and others. So just to give you a brief thing, so in this oral cavity, so this is the upper and lower lip, the tongue, the dorsal and the ventral surface of it. Now, whatever this projection is there, where the teeth are embedded, that is called the alveolar ridges. That is called the alveolus. So upper and lower, and one behind the third molar, which rests on the ramus of this one, is called retromandibular trigone. Okay, and the hard palate as well. Now, inspection and palpation goes as in any other surgical ulcer or lump. Correct? I don't want to spend time on that because you already know about that. So once you do that, you actually have to go ahead and do the ideal also, ideal or medial, to see if any extent has been there in the oropharynx or the hypopharynx, or is there any second primaries. As I told you, field cancerization, right? It can be there. Okay, all these things you will do the endoscopic evaluation as well, and the neck, of course, you will see if any palpable neck nodes are there, or if they're fixed, or any other. Yes, sir. Definitely, sir. So the same way he is going to till the larynx, whenever they smoke, the smoke is going to affect all these things, including nasopharynx. That is why we usually do the nose and the throat, both of them, including that. And actually, in one of our cases, one person had oral malignancy. And subsequently, when I actually did the VDL, we saw there is some like growth in the left piriform fossa, sir. And that one there was a big confusion about it. They were thinking it is a food he has eaten. But then finally, we actually got the scan done and it was proven that he had second primary also. So similarly, we have seen such cases. Now, neck exam. It is one. I have not mentioned so many, as I told you, I have mentioned only the main ones. It is, so any infection which is going to cause chronic inflammation, it is going to reduce the immunity around there. So 2 or 3 factors are going to add up, going to be there. Now, even before we examine, if we have the knowledge of, if a lesion is in alveolus, how will it spread? If a lesion is in tongue, how will it spread? If you have that idea, you can search where all it can go, correct? So coming to the first picture here, so here you can see this lump is in the inferior gingivo-buccal sulcus, correct? So the gingiva coming onto the mandible and the buccal, this is the gingivo-buccal sulcus. It has the propensity to get spread into the mandible itself and to the skin either ways, okay? If a thing is in the RMT or near the maxilla, it can go into the maxilla itself. It can go near the pterygoid plates, or it can go to the temporal fossa also, right? And when this is the same another representation of the RMT. So it can go to the maxilla, it can go to the mandible, go to the tongue medially. So many places it can go. Then here, this is the posterior part of the tongue. Okay, it has more propensity to go to the oropharynx, floor of the mouth anteriorly, and to the soft palate as well. We have seen such patients who come in very advanced stage. And now this is the anterior part of the tongue where it can cross beyond the median raphe, go to the like vascular invasions and to the floor of the mouth as well. The same thing here, the very anteriorly, or this is the floor of the mouth lesion where it has more chances of spreading to the mandible, floor of the, beyond the mylohyoid muscle to the tongue and behind also. It can sometimes go near the hyoid bone and cause dysphagia also. Now the upper one, again, as easy as that, it goes to the skin, maxilla and retromolar. So we have done the clinical evaluation. We see so and so is the lesion. This is where it has spread, and this is his neck condition. We have seen all that. Now, what do you do? Most of the times we go ahead for the biopsy. Correct? There are multiple types of it. You can do brush biopsy, punch biopsy, incisional, excisional, and exfoliative. Okay. So the most common one which we do is incisional or punch biopsy itself. Yes, sir. Outpatient. Local. Outpatient. The FNAC is very limited, as you know, the information it gives. However, in deep-seated tongue lesions, you have no other thing to actually ultrasound guided FNACs are unknown thing. Okay, a small probe will come where you can see and then do that. Now, coming to the radiological one, it is the most common one is CT, correct? The next one is contrast enhanced MRIs and PET CT scans. In few places where it is not available, they always do ultrasound or X-rays also in very small setups. Now, if you can see here, so this is a lesion in the buccal cavity mucosa. So whenever they are trying to get the lesion in the buccal cavity mucosa during the CT scan, they have this puff cheek technique. They just fill up the air. Can you see this black pocket of air here? That is because of the puff cheek technique. And that is the reason you are able to see the whole lesion as well. Okay, so this is the axial lesion here. Now, here if you can see, there is a lesion here in the floor of the mouth or involving the tongue also, which is going on to the mandible. Can you see this? So here you have a full range of the mandible, but here you are not having that because it is already kind of infiltrated by the tumor. Okay, now this is MRI, correct? Most of the times, where do we do MRI? 2 or 3 reasons. One is the tongue or soft tissue lesions like tongue, soft palate, that is in oropharynx, floor of the mouth. Second is to see early invasion of bone marrow. MRI is better than CT in that aspect. Okay. So, for example, if there is a lesion which is infiltrating the mandible, you can see grossly like this. But if the bone marrow has been infiltrated, that will be better off seen on an MRI in the early stages. Okay. So here, can you see this? This is the tongue lesion. Okay. So this is the mandible. So this part is a mandible. Can you see? There is already a contrast enhanced lesion over there. Now, this is our overall representation of the radiological examinations according to one author, need not be universally followed. So in the oral tongue and floor, as I told you, contrast enhanced MRI is the best thing. The gingival and buccal sulcus, it is mostly CT scan itself. Okay, RMT also, it is mostly CT scan. Only this one is where you are suspecting mandibular invasion in the early stages and you are not able to make out when you take the MRI. Okay, hard palate, I would suggest CT itself, and this person tells it is MRI because high accuracy of marrow and perineural invasion. He has given the reason here. And lip, it is MDCT as well. Now, when do we get PET CT scan? Most of the times when you actually do your first tier of radiological investigations, your pathological and your clinical evaluation, you will get an idea how bad is the disease. If you feel it is more than T3, T4 level, or if there is any depth of invasion in the biopsy itself, some people can give you that information. If it is more than 5 mm, that means there are high chances of it to have a distant metastasis. So in such cases, you can get it done. And mostly PET CT is important for post-therapy, that is post-chemotherapy, post-radiotherapy. For such people to see the response, PET CT is important.
when you do PET CT, then you are suspecting the advanced disease. How you don't wait for me to ask 3-4 questions to get an answer. So it's very important to consider, if you suspect it to be locally advanced and advanced malignancy, one is for example, any surgery is quite extensive, and you can't consider doing a very extensive surgery in a patient who has only one extension. So, but you have to, when old back and say, and then other thing is when you give them evaluation as a case study, and you give the response, then you can consider whether you want to go into local research. So for that, those symptoms you want to get fixed. So basically, not standard of care in the diagnostic evaluation of oral cancer. So it's specific circumstances we can do it. But as Madam said, if after therapy you want to follow up these patients for the recurrence, then basically becomes a more things.
So here in this picture, this was a patient who was having in the RMT region. You can see the glow here, and also neck nodes were there. So after we did the mandibular excision and also wide local excision with the neck dissection, he also underwent RT also. So this is post that treatment. You can see that there is disappearance of the lesion. Now, so this one is a again, this is a second scenario where you are suspecting distant metastasis and you want to see the whole staging, the whole evaluation is to get an idea, what am I going to do with the patient and how long is he going to live despite this one. So prognosis and management is the two main things for all our investigations. Okay. So here you can see that there is a lesion in the lungs as well. As I told you, the staging, the whole investigation is for where does the patient stand? What am I going to do with him next? And how long has he got? Or how better can he be with the treatment which I'm going to provide? Right. So AJCC is the main thing, which every other cancer is staged by the same thing. So it is helpful in decision making during the management and also explaining the prognosis to the patient and for our own knowledge how bad the disease is. So nodal metastasis, if it is seen, it is known to reduce the survival risk by 40%. Okay. So recently, a professor called Belcher et al. He reported 5-year survival rate for these oral cavity cancers. The stage 1, they had 72% of the survival. Stage 2, it drops to 54%. Stage 3 to 37%, and stage 4 by 29%. If you see a person who comes with early lesion, there are high chances, nearly 80%. If he comes with an advanced one, there is hardly 29%. Okay. Now, I'm sure you all must be knowing about this. So on a average, grossly, we can say T1 is less than 2 centimeters. Right now, in the 8th edition, we have added about the depth of invasion. So what is depth of invasion? If you can see this picture in here, there is something called as tumor thickness and also depth of invasion. There are two things, correct? Tumor thickness is from the highest point of the tumor growth till its base. That is the tumor thickness. More than that, we are interested in depth of invasion. That is how much of tumor has entered into the stroma beyond the epithelium. How much has it entered? That is the depth of invasion. Okay. So right now that is very important. If it is less than 5 mm, it is still good. Okay. That's how you can see the staging as well. Tumor less than 2 centimeters or less than 5 mm of. If it is more than 5 mm of DOI, that is depth of invasion, that comes under second, or if the tumor is 2 to 4 centimeters. The third one is more than 4 centimeters or any tumor which is having more than 10 mm of DOI. T4A and B are there. So this is very important. That is tumor invades through the cortical bones. They involve the inferior alveolar nerve or the floor of the mouth or to the mandible, maxilla, masticator space. All these things, the skin of the maxilla, sorry. So these are all in 4A. 4B is your masticator space. It goes to your carotid or main important structures. That is your 4D. Node, we all know about it. One is less than 3 centimeters. Next is 3 to 6 centimeters. It has A, B, and C. A is one side, B is multiple, and C is contralateral as well. Then we have 3A and 3B, that is metastasis is more than 6 centimeters in size, but ENE is negative. What is this ENE which they have added again is extranodal extension. If it is positive, finally you can jump to 3B. Okay. And of course, we know metastasis 0 and 1. If it is not there, it is 0. If it is there, you are supposed to mention 1 and mention the place as well where it is, if it is multiple or single. Now, coming to the stage 0, we all know that if the in situ 1 is there, and if it is not even 1 centimeter, you can stage it as 0. And in stage 1, T1, there is no nodes. In the stage 2, also same thing, T2, no nodes. Okay. In the stage 3, either the tumor is T3 or any T, meaning 1, 2, 3, and N is there. Nodes are there. In stage 4, A and B, here the thing is the tumor is already T4A with nodes. Okay. And here the nodes will be of N0, N1, or N2. If it becomes N3, then it goes directly to the 4B. And 4C, of course, is any metastasis. Let it be whatever the T or N, but if it is metastasis, it will go to stage 4C. Now, coming to the treatment, like there has been mention of these oral cavity tumors as long back as 400 BCE in Smith Papyrus. It's a surgical oncology written document. Okay, I just got 1 or 2 lines of it. So they said oral cavity tumors were treated with honey, oil, and cinnamon. All these 3 things, they used to just rub it over and they used to leave it alone. Okay. And coming to the 1957s and all that, this British and French people, they started this thing called as glossectomies for the tongue cancers. How did they do? They used to strangulate the tongue. Whatever the part was there, they used to make a way around it, strangulate it, cut it. The bleeding used to be stopped by cauterization by a hot rod. The hot rod used to be kept there. Imagine this is in 1700s where anesthesia was not there. So we have come a long way in the treatment, correct? So generally speaking, we always know in every treatment, actually, it depends on the disease factors or the tumor factors, patient factors, and the doctor or facility factors, correct? The tumor factors, how much is the stage? Is it 4B or A or 1, stage 1? Or accessibility of it. Where is the tumor? Is it in the base of the tongue? Is it like, in the RMT, or is it in the maxilla? The accessibility of it also is important. Prognostic factors, like is it just like the DOI I mentioned you? All these things, are they in the favorable conditions or bad conditions? Metastasis, has it already spread? So these are all the tumor conditions which we have. Okay. The patient factors, there are a lot of them. To mention a few, age is one thing. Okay. If the person comes to us in a 90 years old and he's having that, you will always weigh the things. And age is not just the number. We also have to look at the ECOG status, the performance status. Even the person is 90 years, and if he's able to walk like a 60 or 70 years old, we can still perform surgeries well on them, right? The ethnicity also, why that is important. A person comes from a rural background somewhere, and they have access to the herbal medicine than us. They're going to go there, correct? They believe in that, they go there. And most of the times they progress to the later stages and then they come to us. So the ethnicity is important. Affordability. Is the patient able to afford what the care you are going to give? Caregiver. So you will do all the morbid surgeries. Yes, you are a good surgeon. You have done all that. You have done good job. But is there anybody who is going to take care? The post-surgery is the bad part. How the person is going to have the food, how the person is going to be taken care of is very important. Does he have the support? And geographical barrier. If a person is somewhere in very rural, where there is no road connectivity also to come here, that also is important. Now, coming to the doctor factors, how the expertise of them, the values of them. When there is a small one here, they are going to go when the pet city marts kunbani, ad marts kunbani, the values are important actually. The thing to do good, that value is very important for a doctor. That person will become a good doctor according to me. Facilities, reconstruction, and the following, after the surgery, are there facilities for radiotherapy? Are there facilities for chemotherapy? Do you have a referral system? All these things will come into matter. Now, usually the management is mainly given by NCCN guidelines. Okay, but I felt this particular book, this is called Contemporary Oral Oncology. The questions they have put here, they make sense actually. So what are all this? What is the intent of my treatment? Is it curative or palliative? Should the primary treatment modality be surgery or radiation? Okay. Is it necessary to address the neck metastasis? What type of neck dissection am I going to do? If it is N0, if it is N+. Indications for the adjuvant radiation or chemoradiation. Induction chemotherapy, is it important? Is a stage so advanced that I need to reduce the size by giving induction chemoradiation, then go ahead. This is all very important. Then is there indication for primary chemoradiation? First only you will give CTRT, then later think about neck dissection or size reduction. What is the best supportive care? All these things are very important for any surgery actually, but in neck, this neck and head and neck, these are the main questions. So in the curative intent, in the T1 is there, single modality, it is either by surgery or radiotherapy, but most of the times it is surgery. Actually, Stella Maran says there is high curative rates with the surgery than the radiotherapy as a primary modality. Okay, radiologists, radiotherapists, they have another thing to say, but this is what it is. T2 to T4A, N1 to N3 and M0, mostly you will be doing surgery followed by radiation. You'll be asking yourself these 3 or 4 questions. How am I going to address the neck? How am I going to, which type of neck dissection am I going to do? All these questions you will have. Any T or any N M0 with close margin. So once you have done the surgery, you send it for frozen section. You see a close margin. What are you going to do? That is, you will be resected. First of all, if you are still in the operation theater. Then once your surgery is done, then you get the pathology reports. Like our hospital, we don't have a frozen. Okay. Then what are you going to do? If you think it can be resected by the surgery, please go ahead with that. Okay. If you feel the patient can't be taken to OT again, give the CTR. Okay. Now, coming to the palliative intent, T4B, unresectable, everything, most of the times it is chemoradiation and immunotherapy only. Okay. Any T, any one, N and M1 is chemotherapy and or radiotherapy and supportive care. Okay. This is the simplest possible. This one you can take a picture of it or anything, because the NCCN is very confusing or it is time consuming. This is very easy. So T1 and N0, that is the stage 1, you are going to do primary radiation or primary surgery. If it is a primary surgery, you will see if it is a superficial lesion or a deep lesion. If it is a superficial lesion, that means less than 4 mm DOI, which you will get by the biopsy itself. You will just do the excision of it and observe. You don't have to do neck because it is so small, superficial lesion. Next, if the deep lesion is there, then you'll have to consider, yes, I have to address the neck. Once it crosses that basement membrane, goes into the stroma, there are high chances of metastasis to the regional nodes at least. So then you will do selective neck dissection. We have discussed regarding the neck dissections, right? Where you will do 1 to 3, where you will do 1 to 4, everything. If it is tongue, you will do 1 to 4. The rest of the places, mostly you will do 1 to 3. Okay. So now in the pathology, after you, okay, we will come to that later. So you will do the deep lesion excision and also the neck dissection, correct? Now, next coming to T1 to T4A and N1, where there is N1, you are seeing a node which is there, definitely you will have to do. So if the primary surgery you will do, and you will do a selective neck dissection in T1 to N4A, and when it is N2, meaning the size is more than 3 centimeters, or there are multiple ones, or there is contralateral one, you will not think about the SND, but you will go for the MRND. Okay. One side, either side depends on 2A, 2B, 2C. Okay. And also the primary tumor. If the primary tumor is crossing your midline, please go ahead with bilateral. Don't take a chance. Okay. So once you have done all this neck dissection, then your pathology report comes. And it says, yes, N0 was there, not many lymph nodes were there, you just no need to give anything, observe. If they say pathology, if it is more than N1, better to give adjuvant RT to both the primary site and the next site. If there are high risk factors like capsular invasion, EME, okay, and DOI is more than 5 mm. Some people, they keep it as 3 mm, this radiotherapy, radiation oncology people. So 5 mm at least. Okay. So these many things you will give adjuvant CT plus RT. Okay, this is the easiest possible way to explain. So just to simplify it, I've just put it into this one. If a person comes to me, I'm going to see how big is the lesion, if it is T1 or T2, and neck is there or not. So even if neck is 0, I'm going to go ahead and do SND. Okay, wide local excision, meaning the tumor along with that 1 centimeter at least. Okay, the gap, that is a wide local tumor excision. Then neck, that is selective neck dissection I'm going to do. Then what comes next? I have excised. There is a defect there. You have to reconstruct. Correct? How am I going to reconstruct? Do I have the backup? or do I have to do it locally? Most of the T1, T2 lesions, it can be done locally itself, like a nasolabial flap or a palatal flap or fan flap. There is facial artery myocutaneous flap. All these things we can do that. Okay? Or they can take a FRAF. So that is the reconstruction. We all must have this planning. Now coming to the T3 and T4, now there is bigger one. And if at all, if it is in the last part of the tongue, the accessibility is bad. If it is the RMT going into the maxilla, then I'll be thinking of lip split, okay, angle split, mandibulotomy. I need accessibility first because I cannot take a chance to get the patient back again. I need to do the full surgery here itself. That must be the intent to go in. However, the results are, but that is the intention. Okay, wide local excision, at least 1 centimeter has to be there. Ipsilateral or bilateral neck will be there. I told you the conditions where you will do bilateral neck. Reconstruction, definitely the local is not going to be possible because it is more than 4 centimeters or so. And you will be doing with FAM. FAM still can be harvested 10 centimeters. FAM is here, faciomyocutaneous here. You can take an eyelid here and do it. Okay, that can be taken inside only and done. Scapular grafts, and we have now fibula comes into play. Your anterolateral thigh graft will come. So many flaps are there. More PMMC, that is a working horse in rural side. So as I told you, NCCN is pretty confusing or complicated, but that is the standard. Okay, whatever I told you, it is very simplified version for you, but this is the usual standard. I have mentioned it here, and also I have attached the NCCN guidelines for you people. Please go through that. Now, when a recurrence happens, what will you do? Is it a local recurrence, or is it has they had a RT or not? All these things you'll keep in mind. So if it is resectable, please go ahead, do the surgery. Surgery is the best. If you can take out whatever is there, that is the best. Later you can give adjuvant treatments. Okay. And if it is local recurrence or second primary with prior RT, then again, resectable is that please go ahead and do the surgery. Unresectable, then re-irradiate the area or give chemoradiotherapy or immunotherapy also. So when you give a person definitive RT, all this while we spoke about the surgery followed by that. Now definitive RT and systemic therapy, you will see if there is clinical response. If there is clinical response, please observe, follow up, that's it. In the primary site, complete clinical response is there. When they had node, you see if there is residual tumor in the neck by the PET CT, correct? If there is, please do neck dissection. If there is complete response, post-treatment evaluation has to be done. If it is negative, observe. If it is positive, do neck dissection. If the primary site has less clinical response, then please go ahead and do the surgery and neck dissection as indicated. Now don't take a chance and play around. Now, planning through the surgery is a big thing. As I told you, you have to see the clinical, radiological, pathological work. It all has to come up to this stage. Ancillary references, this is equally important. A nutritionist must be at your hand, okay? Speech and swallow therapist, physiotherapist, and psychological counseling is very important, and dental checkups as well. Anesthesia evaluation, incision site and type of it, accessibility of the tumor, reconstruction, consent for the tracheostomy or PEG. You are just doing a big lesion, okay? Then you're going beyond the midline. You have to do a tracheostomy for a while at least. So these are all the planning you have to do. Now, mandibulectomy, and so few things at least you need to know. I cannot go into the each and every detail, but mandibulectomy, glossectomy, and maxillectomy, you need to have slight idea what are all the types of it. So here, if you can see, so there is a part of mandible which is taken off, correct? This is called segmental mandibulectomy. Marginal mandibulectomy. So marginal can be of two things. If this is the thickness, okay, I'm cutting just sagittally like this, I'm taking, that is also marginal. If this is the breadth of it, I'm taking off here, that is also marginal. Basically, there is continuity between the whole mandible. Continuity is still there. That is your marginal. Next is segmental. So there is a whole part with the whole thickness, and this one, it has been taken off. This is the segmental. Now, this is hemimandibulectomy. From your median point till the condyle and this one also, that is called segment. It is a type of segmental actually. It is called hemimandibulectomy. Now, this is hemimandibulectomy, but without disarticulation. What do you mean by that? Your coronoid process and the condyle are spared here. Only the part which is required has been taken off. Okay. Sometimes it is called partial mandibulectomy also, to put it very simply, but it is hemimandibulectomy without disarticulation. Now, can any one of you tell what this is? See, to give you this one. So this is the ear, this is the mouth. Here, this is a neck incision, and this is the mandible. What type of fit this is? Correct. And here you can see, okay, this is the maxilla, this is the mandible. Can you see this cut surface here? This and here. What is this? Segmental. Now, this one is from the mid line. This is hemimandibulectomy. Now, coming to the glossectomy types. We have type 1 where only superficial lesions are there and you take it off with a laser or cautery or this one incision. That is mucosectomy only mucosa. If you can see in the second picture, there is no depth of this lesion or the excision. Okay. Now, coming to the second type, here the depth is more, meaning the muscles also are taken along with a part of this one. So this is called partial glossectomy. Now, this one is hemiglossectomy, where half of it is taken off. Here also half of the thing is taken off, but only to restrained area. That's all. This is still hemiglossectomy. Now, 4 is subtotal or near total. The 5 is total glossectomy. Okay. Now, the first one, this one, what can this be? Mucosectomy. So here, a part of it is taken off, that is partial. And here, this is hemi. Okay. Here, this is actually a visor incision is given and it is a pull-through technique. Okay. You go from here, you release the muscles from your mandible, you take the whole tongue along with the floor of the mucosa, pull it downwards and cut how much ever you want. Very good accessibility instead of mandibulotomy. Okay. So this is the total glossectomy, near total glossectomy. Now, coming to maxillectomy, it has a staging also. You might have to learn for your entrances. It is Brown's classification. Okay. So it has 2 components. One is vertical, one is horizontal, as you can see here. So this first one, it is just maxillectomy. It is not going to cause any oronasal fistula. First one. Okay. The second one is inferior maxillectomy, or it is not going to involve any orbit. The third one, it is going to involve the floor of the orbit. The fourth one, it is going to involve orbital enucleation. And here it is going to spare the premaxilla, only the orbit and the rest of the maxillary contents. And here it is about nasomaxillary defect, not the oromaxillary, it is nasomaxillary defect. And the horizontal component, you have a small defect without involving any dental alveolus. Here it is a less than equal. Then here it is premaxilla. Premaxilla is the front few teeth. Okay. And here it is more than half. So depending on that, you will see how much maxillectomy you are going to do. And the reconstruction also is mainly depending on the Brown's classification. And the type of incision which you can give is in this picture. So this is with this and this. This is a Weber-Ferguson incision which involves the lip as well. Okay, this is the lateral rhinotomy. Okay, this, if you go beyond it here to see ethmoidal things also, that is the Lynch modification, and this is the subciliary extension. Now here, so this is the maxillectomy, right? And here in this picture, it is the total maxillectomy without involving the eye. And in this picture, you can see this also is hemi, like on one part, it has been taken off. We are almost towards the end of the presentation, only radiotherapy and chemotherapy. As I told you, primary also is given, but the primary treatment with radiotherapy potentially causes greater morbidity and less effective than this one. What are all the side effects of the radiotherapy? We also do have surgery, also has a lot of this one, I'm telling, but these are all long lasting. Yeah, that's right. What are all there? Mucositis, xerostomia, loss of taste, hypothyroidism, because it involves your thyroid and this one. Okay. So there is a lot of morbidity in that. So when do you actually give that? Yes, sir. Yes, sir. Yes, sir. So when I was in HCG, we only used to give IMRT or IGRT only, sir. In spite of that, when we get the thyroid profile done in a month's period of time, more TSH was more. And also we had studied that a person. Calcium is not an issue somehow. Thyroid is more susceptible. And also we had seen that there were few, the taste is completely gone, sir. That is also because of radiotherapy itself. So the primary is one extent where you give it for the secondary, that is inevitable. We have to give when there are adverse prognostic factors. So what are all there? Bulky tumor with significant risk, recurrence, histology, histologically positive margins, So what is positive? What is closed margins? Can anybody tell? In otherwise also you guys do this one. No? Where have you seen closed margins and this? In oral cavity?
The therapy closed for trachea will be considered primary radiotherapy, and surgery is not either possible or difficult. Those for most of the radiotherapy where you the different margins of involved. Radiotherapy margins.
Yes, sir. The primary one will be.
The side effects also like this.
Yes, sir.
So when it comes to having rules of even if it means may potentially be margin. Things are very sense.
Correct.
For how many doors will be, instead of 45 to 75 days.
75 days, yes, sir. Most probably it will be around 62, 66, 60, 70 ಹಾಗೇನೇ ಇರುತ್ತೆ. And it is over a period of 3 to 4 weeks. And sometimes if they have more prognostic factors, they will be given CTRT. So along with that also. So you'll have to see the patients. There are few reports, sir, but not practically done anywhere. Not much, sir. Not much here. They do the induction chemo NACT, sir, neoadjuvant chemotherapy. That in very advanced diseases and very bulky diseases to reduce the size of it, especially in the tongue, and if the neck nodes are very huge, they do it, sir. After that surgery and after that CTRT will be given. So these are all the places where it is given. So coming back to the point I was talking, so there is closed margins. What is closed margins? What is positive margins? So you have to take 5 mm, 3 mm, 1 mm. 5 mm is safe, you are safe. If it is less than 3 mm, it is close. Okay, and if it is 1, it is positive. So systemic therapy, again, chemotherapy or immunotherapy is there. I'm not the right person to talk about this, but most of the times platinum-based agents are what is being used, like cisplatin or carboplatin are the main things which are used. Okay, docetaxel and fluoroaerosol also will be used. DCF regimen is one of the most common things. And European-based EORTC trial by Bernier et al., they actually did the adjuvant therapy or cisplatin-based chemoradiation, and they said that addition of chemotherapy to radiotherapy, which significantly improves the survival rate. Okay, and use of cetuximab synchronous with radiotherapy in those patients unsuitable with the platinum-based. Now, immunotherapy, again, you have few checkpoints. For example, PD-1, that is like pembrolizumab and nivolumab, and cetuximab is for the, like, which targets the EGFR. PD-1 or PDL-1 is dostarlimab. Okay, so these are all the immunotherapy. Just to mention them, again, I'm not the right person to talk about them. They are very complicated drugs. Now, that is the end of the presentation. Just the last one small thing is, the ribbons, they do have colors and they are different for each disease actually. If you can see, for head and neck, from the beginning of my slides, you can see that this is a head and neck cancer ribbon. Similarly, you have breast cancer and all this. That's it. You got any questions?
In the case of nutrition affect
Well, that's a good question. The person won't be able to. Okay, so if it is a hemiglossectomy, partial glossectomy, there are very good reconstruction options right now with the FRAF. Okay, the FRAF or ALT also for that matter, small ones. So they are going to make it look like the tongue itself, where especially this is affected when the tip is affected, the speech is problem, and also base is affected, the nutrition is problem because they can't swallow properly. They will require rehabilitation. That's why I told you this ancillary services is very important along with us. The rehabilitation of the speech and swallow is very important. We had seen 1 or 2 patients where near total or total glossectomy people also were able to swallow with proper rehabilitation. And few silicone-based, like they do 3D printing, right? Similarly, they were doing a pipe kind of thing, not a straw, but a pipe kind of thing, where it surpasses or it has that curvature of the tongue. When you feed anything here, it will go directly to your this one. There are very advanced things which are coming up. You need a good dental team for that. And also speech and swallow therapy.
The 3D printing for
maxilla happening, sir, everywhere. It's titanium only for the mandibulectomy, the fixature, sir. But the 3D printing which is happening, like Dr. Chauhan actually, he is doing that. They get the 3D printing with the material is different, sir, not titanium. I'm not sure about that material, that one. But in HCG, we always used to go for fibula flaps, sir. That one is the best organic one which we used to do. But that is happening in many places of country now.
Dr. Joshna, excellent talk. Very well covered. Thank you.
Sir, I'm sorry.
After the idea, this, algorithm, fibula, then they will not show.
Yes, sir, correct. That is the reason. In the this one, that is why it is very important to go for the fibular graft, scapular graft, ilia crest graft, where the bone is there, where they can actually have the implants.
Joshna, excellent talk. Thank you.
Sir. Thank you, sir.
So I think there are no questions. This is outstanding disposition of what should we do, the epidemiology, status, technology, clinical features, epidemiology, scientific treatment, and that's good. It's coming from the movie. Let's very people understand the benefits from the one statistics. Please probably share the
It is already shared, sir.
things or we go through the human because these things
Thank you so much. Hope it was helpful.
Okay, small class, that's more answer. No, no. So you manage, how did you,